Okay, let's unpack this. You know how incredible our immune system is, right? It's constantly working, this invisible shield protecting us from, well, countless threats.
Yeah.
But what happens when this intricate defense system goes a little, well, rogue?
Yeah, that's the key question.
Today, we're taking a deep dive into the fascinating, sometimes surprising world of immune system disorders. We're using a chapter from Microbiology, an introduction as our guide, and our mission is to extract the most important nuggets of knowledge from this.
Right?
We want to help you quickly become well-informed on how our bodies can sometimes overreact, attack themselves, or even, struggle to defend against common
Get
invaders.
ready for some aha moment.
Exactly. Because here's where it gets really interesting.
What's fascinating here is that the very mechanisms designed for our protection can, under certain conditions, lead to undesirable or even, well, damaging effects.
Right?
We'll explore everything from, say, the sniffles of hay fever to serious conditions like autoimmune diseases and, of course, the global impact of HIV.
Understanding the why.
Exactly. The why behind these complex interactions and their real-world implications, whether that's in a clinic or just in our daily lives.
So let's kick things off with hypersensitivity, essentially. When our immune system overreacts,
Hmm.
this isn't just a minor annoyance. It's an immune response that causes undesirable effects, what we commonly call allergies.
Right. And it happens when someone has been sensitized by a previous exposure to an antigen or, an allergen.
Okay, so it's a repeat exposure thing.
Correct. And these aren't all the same. There are four principal types of hypersensitivity reactions, each unfolding a bit differently.
4 types.
Yeah. Type I, like hay fever, is immediate. Type 2, that's seen in things like blood transfusion reactions, involves cells being directly attacked.
Okay.
Then type 3, where these immune complexes cause inflammation. And finally, type 4, which is a delayed reaction, think poison ivy.
That delayed one, right. So why are allergies and, other immune-related disorders seemingly on the rise, especially in developed nations?
That's a huge question.
Turns out our microbial friends might hold a surprising clue.
Well, this raises an important point. Could modern hygiene practices be maybe inadvertently contributing?
How so?
The hygiene hypothesis suggests that if children aren't exposed to a really diverse range of microorganisms early in life, their immune system might not develop proper tolerance.
Oh.
This can lead to an imbalance in our normal gut bacteria, what we call dysbiosis, making the immune system more likely to, well, overreact to harmless things.
Wow, that's a huge real-world impact. Our source points to studies showing how kids growing up on farms, with all that diverse microbial exposure, often have lower rates of allergies and asthma compared to, say, urban kids.
Absolutely. And this concept even extends to inflammatory bowel diseases like Crohn's disease, where dysbiosis seems to play a significant role.
So it's all connected to the gut microbes.
It often is. And this is why something like fecal transplants are gaining traction. They're effectively hitting a reset button for the gut microbiome, successfully treating severe Clostridium difficile infections, and even showing promise for IBD. It just illustrates how powerful restoring that healthy microbial balance may be.
Fascinating. Okay, let's talk about type I anaphylactic reactions, the immediate overreactions.
The really fast ones.
Yeah, think about that sudden burst of allergy symptoms. It starts when specific antibodies, IgE, bind to mast cells throughout your body.
Right. These mast cells are loaded and waiting.
And when an allergen reconnects with those antibodies, it triggers these cells to essentially explode, releasing a flood of chemical mediators.
And that explosion, that degranulation, is what unleashes things like histamine.
Ah, histamine, the main culprit.
It's a major one, yeah. Causes those familiar allergy symptoms like swelling and redness, a runny nose from increased mucus, and even making breathing difficult as smooth muscles contract.
And there are others too.
Yes, other mediators prolong these effects, leading to things like the sustained airway constriction you see in asthma.
Okay, so when this reaction goes body-wide and rapid, that's systemic anaphylaxis or anaphylactic shock.
Exactly. And this is a severe, potentially life-threatening situation that can develop in minutes.
Scary fast.
Very. Blood vessels dilate dramatically, causing a dangerous drop in blood pressure, leading to shock. Airways narrow, breathing becomes distressed, rashes can appear.
So what's the treatment?
The immediate treatment for systemic anaphylaxis is epinephrine, an EpiPen, for example.
Right.
This drug constricts blood vessels and rapidly raises blood pressure, which can be absolutely life-saving.
And certain things are higher risk?
Yeah, reactions from injected antigens like insect venom or certain drug allergies like penicillin carry a higher risk of triggering this severe systemic response.
Okay. More commonly, though, we see localized anaphylaxis.
Right. Less severe, usually temporary.
This is what you experience with, say, hay fever from pollen or maybe food allergies.
Mm.
Think itchy eyes, sneezing, or hives after eating something you're sensitive to. Uncomfortable, definitely, but generally not life-threatening.
Correct. For diagnosis, skin tests are often used. A tiny amount of allergen under the skin.
See if you react.
Exactly. Look for that red, itchy wheal. For prevention, there's desensitization or immunotherapy.
Allergy shots.
Pretty much. Giving repeated, increasing doses of the allergen. The idea is to sort of trick the immune system into producing blocking antibodies that intercept the allergen before it triggers the whole cascade.
Does it work well?
Its effectiveness can vary, depending on the person and the allergen.
Okay. Moving on then. Type 2, cytotoxic reactions. This is where our antibodies mistakenly attack our own cells.
Yes, typically IgG or IgM antibodies combine with antigens on the surface of our own cells, marking them for destruction.
And the cells get lysed, burst.
Right, the complement system gets activated, leading to lysis, often within hours.
Where do we see this?
This is most familiar in blood transfusions. Our ABO blood group system is based on specific carbohydrate antigens on red blood cells.
ABOEB.
Exactly. If you receive the wrong blood type, your pre-existing antibodies will attack and destroy those incompatible donor red blood cells. That's why careful blood typing is absolutely critical.
Makes sense. And then there's the Rh system, important for pregnancy.
Very important. Rh factor. Rh-negative individuals don't naturally have anti-Rh antibodies, but they will produce them if they're exposed to Rh-positive blood.
Okay, so how does that affect pregnancy?
This leads us to a critical clinical scenario. Hemolytic disease of the newborn, HDNB.
Right.
If an Rh-negative mother carries an Rh-positive fetus, especially during her first pregnancy, she might get sensitized during birth when a little fetal blood enters her circulation.
Okay, her body sees the Rh plus factor as foreign.
Precisely. Her body produces anti-Rh antibodies. Now, in a subsequent Rh plus pregnancy, these maternal antibodies, which are IgG, can cross the placenta and destroy the fetal red blood cells, leading to severe anemia and jaundice in the newborn. So the question is, how do we prevent this?
There must be a way.
There is. We prevent it with passive immunization using Rojam. It's an injection of anti-Rh antibodies given to the Rh mother during pregnancy and after delivery.
How does that help?
These decoy antibodies essentially find and destroy any fetal Rh plus red blood cells in the mother's system before her own immune system can get activated and mount a full, lasting response.
Clever.
It really is. And this whole concept helps us understand diagnostic nuances, like remember the clinical case of Jessica's newborn.
Yeah, the baby tested positive for HIV antibodies but negative for the virus itself.
Exactly. A positive antibody test in a newborn whose mother is HIV positive often just means the infant has passively acquired maternal antibodies that cross the placenta. Normal pregnancy stuff.
So it doesn't mean the baby has HIV.
Not necessarily. A negative PCR test, which looks for the virus's actual genetic material, confirms there's no active infection at that time. It highlights the difference between just having antibodies and having the virus itself.
Got it. Okay, next up. Type 3 immune complex reactions.
Right. In this case, antibodies and soluble antigens form these small complexes.
Little clumps.
Kind of. And instead of being cleared away properly by phagocytes, these complexes get trapped in the blood vessel walls or in organs like the kidneys.
And that causes problems?
Yes, they activate inflammation, the complement system gets involved, and it causes tissue damage, usually within a few hours to maybe 8 hours.
Like sticky balls of immune debris clogging things up.
That's a decent analogy, yeah. It triggers inflammation wherever they settle. Certain inflammatory kidney conditions, glomerulonephritis can be examples.
Okay, now let's discuss type IEV, delayed cell-mediated reactions. You called this the slow burn.
Right, because they don't typically appear for a day or two.
Mm-hmm.
These involve T cells directly, not antibodies like the other types.
Why the delay?
It just takes time for the T cells and other immune cells, like macrophages, to migrate to the site and accumulate enough to cause a noticeable reaction.
What's a common example?
A classic one is the tuberculosis skin test. If you've been exposed to TB previously, injecting a small amount of its protein into your skin will cause a localized inflammatory reaction, but it takes 1-2 days to show up.
Okay.
Another really common one is allergic contact dermatitis.
Like poison ivy.
Exactly. Or nickel and jewelry, some cosmetics, latex. The first contact sensitizes your T cells. Then subsequent exposures trigger that itchy, often blistering rash, usually days later.
This delayed timing is important clinically then.
Absolutely. It's key to understanding scenarios like a patient who develops a rash days after taking penicillin.
Right, not immediately.
An immediate reaction would point towards an antibody-mediated allergy like type I.
Right.
But a delayed rash, like the one in our source's clinical focus, strongly suggests a type IV cell-mediated response involving those sensitized T cells. Timing really matters in diagnosis.
Makes sense. Now let's talk about perhaps the most, unsettling scenario. Autoimmune diseases. When your own immune system turns against you.
Yeah, it's a profound breakdown. This raises the fundamental question of how our immune system learns to differentiate self from non-self.
How does it normally learn that?
Normally, during fetal development in the thymus, immune cells, specifically T cells, that show reactivity against our own tissues are supposed to be eliminated. It's called clonal deletion or thymic selection.
So they get weeded out.
Ideally, yes.
Yeah.
Autoimmune diseases occur when this self-tolerance fails, and the immune system mistakenly produces autoantibodies or sensitized T cells that attack our own body's tissues.
And it affects women more often.
Strikingly so.
Right.
About 75% of cases affect women. The reasons are complex, likely a mix of hormones, genetics, maybe past infections, even things like vitamin D levels are being looked at as potential triggers.
Wow. And how do these diseases manifest?
They can manifest in different ways depending on what's being attacked. In multiple sclerosis, for instance, the immune system attacks the myelin sheath that protects nerve cells.
Causing neurological problems.
Exactly, disrupting nerve signals. In Graves' disease, abnormal antibodies mimic a hormone, thyroid-stimulating hormone, causing the thyroid gland to go into overdrive.
A hypothyroidism.
Right. And in rheumatoid arthritis, you have immune complexes depositing in the joints, leading to chronic inflammation and severe damage to cartilage and bone.
It really shows how that protective power can be devastating when it's misdirected.
Absolutely.
So if the immune system is so good at identifying non-self, how on earth do we manage organ transplants? Seems like they'd just be rejected immediately.
Exactly. That's the central challenge. Our cells have unique surface molecules, these histocompatibility antigens. Mostly, we talk about the major histocompatibility complex, MHC, or in humans, the human leukocyte antigens, the HLA complex.
Or cellular fingerprint, basically.
A good way to put it. To prevent rejection, the donor and recipient HLA types, along with their ABO blood types, must be matched as closely as possible. It's like trying to find the best possible tissue match.
How is that matching done?
It used to be primarily serological testing, using antibodies. Now, more advanced techniques like PTR are used to match the DNA level, which is much more accurate.
And if it's not a good match?
If the transplant is recognized as non-self, it triggers a powerful attack by the recipient's T cells, antibodies, complement system, the works, leading to rejection.
But some transplants don't trigger rejection as easily.
Right. There are what we call privileged sites in the body. The cornea of the eye is a great example. It typically lacks direct lymphatic vessels, and antibody circulation is limited there.
So the immune system doesn't see it as easily.
Sort of, yeah. Though rejection can still happen if blood vessels grow into it. The brain is another relatively privileged site due to the blood-brain barrier.
And this is where stem cells become really interesting in transplantation, right?
Oh, absolutely.
Uh-huh.
This is where the future of medicine gets incredibly exciting, using the body's own building blocks.
Tell us about stem cells.
Well, stem cells are basically cells capable of renewing themselves and, crucially, differentiating into various specialized cell types.
Like a blank slate cell?
In a way. We have embryonic stem cells from blastocysts, which are pluripotent. They can become almost any cell type. And adult stem cells, found after birth, which are usually multipotent, meaning they can form a limited range of cell types.
And we can make them in the lab now, too.
Yes, that's a huge advance.
Mm-hmm.
Induced pluripotent stem cells, or iPSCs. Scientists can essentially reprogram regular adult cells, like skin cells, back into a pluripotent state in the lab.
The potential seems enormous.
It really is. Regenerating damaged heart tissue after a heart attack, creating insulin-producing cells for diabetics, growing new cartilage for arthritis. The list goes on.
Okay, let's switch gears slightly to bone marrow transplants. These are crucial for some immune problems.
Yes, specifically hematopoietic stem cell transplants. They're used for individuals who lack essential immune cells, like B cells and T cells. Essentially, you're transplanting the factory that makes immune cells.
But there's a risk here too, right? Graft versus host disease.
A very serious potential complication, yes. GVHD is sort of the reverse of transplant rejection. Here, the transplanted immune cells from the donor marrow are immunocompetent.
Okay.
And if the recipient's own immune system is weak or non-functional, those transplanted donor cells recognize the recipient's body tissues as non-self and start attacking them.
Wow, the graft attacks the host.
Precisely. And this connects directly back to our clinical case, Melik, the infant with DiGeorge syndrome.
Because he didn't have T cells.
Exactly. He lacked a thymus, so no functional T cells. When he received a blood transfusion, which contained mature, immunocompetent donor lymphocytes, those donor lymphocytes saw Malik's cells as foreign and attacked, causing GVHD.
How was he treated?
With immunosuppressive drugs, including a monoclonal antibody to block T cell function and cyclosporine. It highlights why umbilical cord blood is often preferred for such transplants.
Why is that?
Cord blood contains younger, less immunologically mature stem cells. This often means less stringent HLA matching is required, and the risk of severe GVHD is reduced.
Interesting. And just quickly, the types of grafts.
Sure. An autograft is tissue from yourself, like a skin graft for a burn patient. No rejection. An isograft is between identical twins again, no rejection because they're genetically identical.
Okay.
An allograft is between non-identical individuals of the same species. This is the most common type of transplant, and it always triggers an immune response, hence the need for HLA matching and immunosuppression.
Right. And animal transplants.
Xenotransplantation products.
Yeah.
Using tissues or organs from animals, like pigs. These face hyperacute rejection, a very rapid and severe rejection mediated by pre-existing antibodies against animal antigens. Plus, there are concerns about transferring animal viruses.
So managing allograft rejection relies heavily on immunosuppression.
Absolutely vital. The goal is tricky. Suppress the cell-mediated immunity enough to prevent rejection because T cells are the main drivers.
But not suppress it so much that the patient can't fight off infections.
Exactly. You want to preserve humoral immunity, the antibody response, as much as possible. Drugs like cyclosporine, tacrolimus, and others revolutionize transplantation by selectively targeting T-cell activation pathways.
And some patients can eventually stop these drugs.
It's amazing, right? They're seeing some patients years after surgery who can actually discontinue immunosuppressants. It seems their immune system, maybe after being temporarily chimeric, a mix of donor and recipient cells, learns to tolerate the organ itself. It's a really active area of research into immune tolerance.
Incredible. Okay, next up, the immune system and cancer. Our inner defense, you might say.
Yeah, our bodies actually have this amazing built-in defense against cancer called immune surveillance.
How does that work?
Well, cancer cells undergo changes, transformation, that make them look abnormal or non-self to our immune system. They often acquire unique markers called tumor-associated antigens.
So the immune system can spot them.
Normally, yes. Immune cells, like cytotoxic T lymphocytes, CTLs, and activated macrophages, recognize these markers and eliminate the cancer cells before they can grow into a tumor.
So why do people still get cancer?
Good question. This concept helps explain why cancers are more common in older adults, whose immune systems tend to become less efficient over time immunosenescence, or in people whose immune systems are suppressed for other reasons, like transplant recipients on immunosuppressants. Their internal defenders are just not as effective.
But cancer can also be sneaky, right? It has ways to evade the immune system.
Absolutely.
Yeah.
Sometimes cancer cells don't display strong non-self markers, or they might reproduce so rapidly they simply overwhelm the immune response. Some can even hide in a latent state for years.
Which makes fighting it harder.
Definitely. And this challenge is precisely why immunotherapy for cancer is such a revolutionary and promising field right now.
Moving beyond just chemo and radiation.
Exactly.
Yeah.
We're now harnessing the patient's own immune system to fight the cancer. This includes things like cancer vaccines.
Vaccines for cancer.
Yes. Some are preventive, like the HPV vaccine, which prevents infections that cause cervical and other cancers, or the hepatitis B vaccine for liver cancer.
Okay.
And others are therapeutic, designed to treat existing cancer by boosting the patient's own immune response against their tumor cells.
And what about monoclonal antibodies?
These are a huge part of immunotherapy. They're lab-engineered antibodies designed to do specific jobs. Some can directly target cancer cells, flagging them for destruction. Others might block growth signals that tumors rely on. Some even carry toxins or radiation directly to the cancer cells.
Like guided missiles.
Kind of, yeah. It's about empowering and directing our body's own defense mechanisms much more precisely against the disease.
Okay, let's flip the coin now and talk about immunodeficiencies, when the defenses are down.
Right. This is simply the absence or lack of a sufficient immune response, making individuals vulnerable to infections.
And these can be present from birth.
Yes, those are congenital or primary immunodeficiencies. They're caused by defective or missing genes needed for the immune system to develop or function properly.
Like Malik's case.
Exactly. DeGeorge syndrome involves a defective gene leading to an absent or underdeveloped thymus gland, resulting in a lack of T-cell immunity. These congenital defects can affect various parts of the immune system: B cells, phagocytes, complement.
Any other type.
Acquired or secondary immunodeficiencies. These develop later in life due to external factors.
Such as?
Things like immunosuppressive drugs used for transplants or autoimmune diseases, certain cancers like Hodgkin's lymphoma, malnutrition, or significantly, infectious agents like HIV.
Which brings us to acquired immunodeficiency syndrome, or AIDS, a major acquired immunodeficiency that really changed the world.
It truly did. And this is a story of global health, really, and how understanding the tiniest details of a virus can have the biggest impact.
Where did HIV come from?
Well, what's quite clear now is that HIV-1, which is the predominant strain causing AIDS worldwide, is genetically very closely related to a simian immunodeficiency virus, SIV, found naturally in African monkeys and chimpanzees.
So it jumped from animals to humans?
That's the widely accepted theory, yes. Likely through a bushmeat crossover event, probably in Central Africa sometime in the early 20th century. The earliest known sample is from Kinshasa back in 1920.
Wow, that early.
Yeah, and then modern transportation networks, urbanization, and other social factors played a key role in its eventual spread globally, becoming recognized in the early 1980s.
So tell us about the HIV virus itself.
HIV is a retrovirus. That means its genetic material is RNA, not DNA. It carries two identical copies of its RNA genome, along with crucial enzymes like reverse transcriptase and integrase, all packaged inside a protein core and an outer envelope studded with glycoprotein spikes.
And then those spikes are important.
Very. The main spike protein, GP120, is what attaches to the CD4 receptor found primarily on T helper cells, but also on other immune cells, like macrophages and dendritic cells. It also needs to bind to a co-receptor, like CCR5 or CXCR4, to get in.
So it targets key immune cells?
Precisely. Once attached, another protein, GP41, facilitates the fusion of the viral envelope with the cell membrane, allowing the viral core to enter the cell.
And then the retrovirus part kicks in.
Exactly. Inside the cell, the reverse transcriptase enzyme gets to work, converting the viral RNA into DNA. This is kind of the reverse of the normal flow of genetic information in our cells.
Okay.
Then another enzyme, integrase, inserts this newly made viral DNA into the host cell's own chromosome. At this point, it's called a provirus.
And it just stays there.
It can stay there, latent and hidden for a very long time. This is one way HIV achieves viral evasion.
How else does it hide?
It can remain latent as actual virus particles within vacuoles inside cells. It can also spread directly from an infected cell to an adjacent uninfected cell through cell fusion, effectively dodging antibodies circulating in the bloodstream.
Clever in a sinister way.
And crucially, that reverse transcriptase enzyme is notoriously error-prone. It makes lots of mistakes when copying the RNA to DNA, and it doesn't have a proofreading mechanism.
Leading to mutations.
Exactly. A high mutation rate leads to rapid antigenic changes. The virus constantly generates slightly different versions of itself, making it a moving target for the immune system and complicating vaccine development immensely.
So what are the stages of HIV infection if it's not treated?
Typically, it unfolds in 3 phases. Phase 1 is the acute infection, right after exposure. Viral RNA levels in the blood soar, often reaching millions of copies per milliliter. CD4 plus T cell counts plummet temporarily.
Are there symptoms then?
Often. Yes, flu-like symptoms, maybe swollen lymph nodes, lymphadenopathy, but sometimes it's asymptomatic. Importantly, this is usually when seroconversion occurs, when antibodies against HIV become detectable in the blood.
Okay, phase 2.
Phase 2 is clinical latency, or chronic HIV infection. Here, the CD4 plus T cell numbers start to decline steadily, though it might be slow. HIV replication continues, but at lower levels, mostly happening within lymphatic tissues. Often few major symptoms during this phase, which can last for 10 years or even longer. However, persistent infections like oral thrush, candida, might start to appear, signaling declining immunity.
And phase 3?
Phase 3 is defined as clinical AIDS. This is when the CD4 plus T cell count, drops below a critical threshold, typically 200 cells per microliter of blood. Normal is more like 500 to 1500.
And that's when things get really bad.
Yes. At this stage, the immune system is severely compromised, leaving the individual highly susceptible to a range of severe opportunistic infections and certain cancers. Things like pneumocystis pneumonia, toxoplasmosis, Kaposi sarcoma infections a healthy immune system would easily control. Patients are officially classified as having AIDS during this phase.
Okay, so back to Jessica's baby antibodies were present, which you said happens in phase 1 after seroconversion, but the baby didn't have HIV. How does that work with diagnosis?
Right, this highlights the importance of understanding what the tests detect. Standard tests like ELISA and Western blot detect HIV antibodies.
Not the virus itself.
Correct. So a positive antibody result in a newborn whose mother is HIV positive, like Jessica's baby, often just reflects those passively transferred maternal antibodies.
Got it.
That's why the negative PCR test for HIV DNA was crucial. PCR looks for the actual viral genetic material. A negative result in the infant confirms the virus itself isn't present, meaning no active infection at that time. It's critical to distinguish antibody presence from active viral presence, especially considering the window period.
What's the window period?
That's the time between initial infection and when antibodies become detectable by standard tests. It can be up to 3 months. So if someone recently infected might test negative on an antibody test, a false negative, even though they have the virus.
That's why other tests are needed sometimes.
Exactly. Nucleic acid amplification tests, NATs, like PCR-based assays, can detect the viral RNA or DNA much earlier, typically within 7–10 days of exposure, well before antibodies develop. They're also used to monitor the plasma viral load, PVL, the amount of virus in the blood, which is key for managing treatment.
Okay. How is HIV transmitted?
Transmission requires transfer of or direct contact with infected body fluids. Blood and semen carry the highest concentrations of the virus and are the highest risk fluids. Saliva is extremely low risk.
What are the main routes?
The primary routes are sexual contact with anal receptive intercourse, carrying the highest risk sharing contaminated needles among intravenous drug users, transmission from mother to child during pregnancy, birth, or breastfeeding, and historically through contaminated blood transfusions or organ transplants, though this is very rare now in developed countries due to rigorous testing.
And healthcare workers?
There's a small risk from needle stick injuries, about 0.3%, which is why universal precautions treating all blood and body fluids as potentially infectious are standard practice in healthcare settings.
Looking globally, what's the picture?
AIDS remains a major global health challenge. Around 36 million people are estimated to be living with HIV worldwide. The burden is disproportionately high in sub-Saharan Africa, which accounts for about 70% of all infections and the vast majority of HIV-infected children.
And the main transmission mode worldwide?
Heterosexual intercourse is the most common mode of transmission globally. Intravenous drug use is also a significant factor, particularly in regions like Eastern Europe and parts of Asia.
So what about preventing and treating AIDS? Have we made progress?
Monumental progress, especially in treatment. Prevention strategies are multifaceted. Biomedical approaches like promoting condom use, widespread testing, needle exchange programs.
And behavioral.
Yes, sex education, counseling, promoting safe infant feeding practices for HIV-positive mothers, and structural approaches that address underlying social and economic factors contributing to vulnerability.
What about drugs for prevention?
Yes, that's been a significant development. Pre-exposure prophylaxis, PPRED, involves HIV-negative individuals at high risk taking specific antiretroviral drugs daily to prevent infection. And post-exposure prophylaxis, PP, involves taking antiretrovirals very soon after a potential exposure to reduce the chance of infection.
And for those already infected, you said treatment has transformed things.
Absolutely. Antiretroviral therapy, or sometimes called HAART for highly active antiretroviral therapy, has been revolutionary.
So what does this all mean for someone living with HIV today? It's really gone from, well, a near certain death sentence in the early days
to a manageable chronic condition, at least in places where treatment is accessible.
How does RT work?
It involves using a combination of multiple drugs simultaneously. This is crucial because HIV reproduces so rapidly and mutates so frequently that using just one drug quickly leads to drug-resistant strains.
So a cocktail of drugs.
Exactly. Often combined into a single daily pill now for convenience. These drugs target different stages of the HIV life cycle, often focusing on those unique viral enzymes like reverse transcriptase or integrase, which aren't present in human cells.
What kinds of drugs are there?
Several classes. Fusion and entry inhibitors block the virus from attaching to or entering the host cell. Reverse transcriptase inhibitors, both nucleoside analogs, NRTIs, and non-nucleoside analogs, NRTIs, block that crucial RNA to DNA conversion step. These have dramatically reduced mother-to-child transmission.
What else?
Integrase inhibitors block the viral DNA from being inserted into the host chromosome. And protease inhibitors prevent the virus from assembling new functional virus particles by blocking an enzyme needed to cut viral proteins into their final forms.
So hitting the virus at multiple points.
That's the strategy. But challenges remain. Art doesn't eradicate the virus completely due to those latent reservoirs of hidden provirus in cells. And if treatment is interrupted, the virus can rebound, potentially with drug resistance.
And a vaccine remains elusive.
Frustratingly, yes. Developing an effective HIV vaccine has proven incredibly difficult for several reasons.
Like what?
Well, there's no natural immunity model. No one has ever naturally cleared HIV infection through their immune system alone. Using a weakened live virus, like for measles, is considered too dangerous.
And the virus hides.
Yes, the latency issue is huge. The virus hides as a provirus or within cells. Plus, that high mutation rate means the virus is constantly changing its appearance, making it hard for a vaccine targeting one version to work against others. It also spreads cell to cell, bypassing antibodies.
So it's a tough target.
Extremely tough, and any vaccine would need to be affordable and accessible, especially in the high prevalence regions where it's needed most. Research continues, but it's a major scientific hurdle.
Wow, what a journey through the incredibly complex and sometimes contradictory world of our immune system.
It really is complex.
From, the sneezing fits of hay fever all the way to the intricate battle against HIV, it's just so clear our body's defenses are truly a double-edged sword.
Absolutely, and if we connect this to the bigger picture, the constant evolution of pathogens like HIV, and our own immune responses, it really highlights this dynamic interplay happening within our bodies and, importantly, with our environment. Think back to the hygiene hypothesis.
Right, how our environment shapes immunity.
Exactly. Understanding these mechanisms, hypersensitivity, autoimmunity, transplant rejection, immunodeficiency, it's not just academic. It's absolutely vital for developing life-saving treatments and effective preventive strategies.
It really makes you think about how every tiny detail, every cell, every protein plays such a critical role in our overall health, doesn't it?
It's a delicate balance.
The more we understand these disorders, the more I think we appreciate that delicate balance that most of the time keeps us well.
Well said.
Thank you so much for joining us on this deep dive into the immune system. We really hope you're leaving with a renewed sense of curiosity and feeling a little more well-informed.
Keep asking questions.
Definitely. Keep that curiosity alive, and we'll catch you on the next deep dive.